to, you can do that as well. Next slide. We want to acknowledge on this phenomenally beautiful and very still morning, unlike last night's blowing wind, that we're actually on the land of the Coast Salish peoples that includes the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, and the Métis Charter Community of the Lower Mainland region. Wherever you are in the province, hopefully you're enjoying and tending and learning about the land and the peoples. Acknowledging that we, as visitors to this land, need to hold it and its peoples with respect and commitment to truth and reconciliation. Next slide. So Province-Wide Round is a collaboration between UBC Division of Nephrology and BC Renal. It's supported by our industry partners as well as all of the health authorities, and we thank you for making sure that we as healthcare professionals within the kidney community are as up to date as we can possibly be, and today I think will be no exception of keeping us up to date. Next slide. So today's talk is presented by our fellows. As many of you will know, the fellows often go to, as do others, go to national or international meetings, and have gone to the International Society of Nephrology and the Canadian Society of Nephrology in the last few months. And as a commitment to greater learning, they also come back and tell us what they've found interesting for a bit of show and tell. So I just want to introduce Emily, Lauren Simms, and Nicolas Vendeville. These are our R5s. They're graduating this year in about a month and a half. Emily is the chief resident for the UBC Nephrology in 23-24, originally from Ottawa, and is actually returning to Ottawa after this nephrology fellowship to complete a hypertension fellowship, and is interested in preventive medicine, cardiorenal physiology, hemodialysis, and education. And Dr. Vendeville is a fifth-year resident also here at UBC, and he'll be starting a transplant nephrology in Toronto in July. And Dr. Shah was supposed to be here, but is unfortunately very ill, so we're down to a two-person presentation. And at this point, I want to welcome everybody here and ask Emily and Nicolas to take it away. Just need to unmute yourselves.
Sorry, the computer froze for a second. Is my mic working now?
The mic is working, but no slides yet. And there they are. I just go into slide mode.
Perfect. So
Perfect.
Thank you for the warm introduction. I'm Emily, and Nicolas is going to take over for me in a little bit. And the question that we're going to pose to you or argue for you is kind of what was hot at the World Conference of Nephrology and the CSN General Meeting this year that we were lucky to attend in May. So we have some objectives, and first of all, it was actually to introduce not just us, but all of us, and then highlight some local BC research that's been presented nationally and internationally. And then I'm going to share some content and updates and some late breaking publications, upcoming guidelines, and novel ideas that I think we're going to probably discuss quite a bit. And my content is kind of focused on three big guidelines that are being published in KDIGO in the kind of the 2 years period between 2024 and 2025, including the new CKD guidelines and some of the stuff that's being incorporated into those and will be in future guidelines to look out for, the anemia guidelines that were released for public review this week as a preliminary discussion, and the new vasculitis guidelines. So we don't really have any disclosures or acknowledgements, but we did attend some industry-sponsored dinners and talks, and the anemia guidelines that were just released for public review are not finalized and just open for debate. And there were some slides at least in my slide deck, that have been borrowed from other talks, including a talk by Dr. Levin, and some visual abstracts from #NephJC. So first of all, this is all of us. And this slide took forever to make because the coolest thing about our program is we have people from countries, essentially almost every continent, that are training with us, sharing ideas from around the world, which is very fitting when we're talking about ideas that were presented at an international conference. So I also wanted to say that we have 2 incoming fellows coming in July to look out for Amanda Ames and Suman Lakhi that are going to be our Canadian fellows starting then. But we have numerous other fellows completing their training here, including Jemana, who's here training from Saudi Arabia, effectively as a core fellow, some international fellows from Australia, Lebanon, a couple fellows from Brazil, and transplant fellows from Ireland, Scotland / Nigeria, and Malaysia / the UK, as well as our research trainees. And we also have a Uganda, we occasionally have a visiting Uganda fellow who's been training with us, and Gloria Shambasho just returned to her country and was amazing to have her here with us. And then me. So as Dr. Levin mentioned, I'm originally from Ottawa, but BC has become my home and where I'm looking to stay. And I'm available for locums all over BC starting in July of 2025. So please feel free to reach out if you're looking for someone to cover your practice starting then. And that's my email on the slide. And I'll hand it over to Nicolas to introduce himself.
Hi, so my name's Nicolas. I'm from Montreal, and as you heard from Dr. Levin, I'll be doing transplant nephrology fellowship in Toronto. I'm also interested in nephro-oncology as well, so I'll probably be in training for a long time, but that's okay. So that's it for me. I'll hand it back to Emily.
Then lastly, our poor fellow Michael couldn't be here today because he's quite sick, but his interests include preventative medicine and home dialysis therapies. And this is his email, and he'll be done in 2025, figuring out what he wants to do afterwards. So moving into kind of the meat, at least of my presentation. So I'm going to talk mostly about stuff from the World Congress of Nephrology, or the ISN meeting. I'm going to talk about some BC and BA, some local BC stuff that was presented in Buenos Aires. We'll talk about point of care creatinine testing, how everything in CKD care is going to be looking more finerenone in the next while, and we might be going with the results of the FLOW trial, which is going to be dropped at Stockholm, and I was privileged to see some early updates on when I was down south. We're also going to talk about some pivots from the pivotal trial into the new anemia guidelines, and ask the question if Plexi is back in the vasculitis guidelines, or if it ever really left. So first of all, we should all take a second and congratulate Dr. Levin for being awarded the prestigious Jean Hamburger, not hamburger, Hamburger Award for Outstanding Research in Nephrology with a Clinical Emphasis. And we were so lucky to see her get such a prestigious award, where she gave a very moving address highlighting a lot of people that have been standing behind her at BC Renal. But she got an amazing award, and we should all be really proud of her. And there was also a bunch of BC research that was presented in Buenos Aires as well, including some oral presentations by Dr. Adira Levin and Carolyn Stigant on both CKD care and on environmental health and nephrology. And our local Fraser Health nephrologist Shannon Wong presented a poster with Dr. Stigant as well, looking at the carbon footprint of BC patients that travel for kidney care. And there was other posters that were presented too, including some about advancing self-management support in adults with kidney care disease, more about environmental research and peritoneal dialysis, and also some patient presentations about the importance of the patient voice. So give everybody a round of applause, as there's been tons of BC research that's been highlighted internationally. And we also had a lot of fun. We went out to celebrate Dr. Levin. We went to the opera and just enjoyed a lot of food. And me personally, I ate a lot of steak. And in Montreal, where we went 2 weeks ago, we also had a lot of fun. And if you know Dave Percal, you'll know that this is the face that he's making when he's having a great time. And there was some BC research that was presented in Montreal as well. Dr. Stigant also traveled to Montreal, where he gave more talks on planetary health and CKD and nephrology care. And we were lucky enough with a couple of our co-fellows to attend the CSN Fellows pre-course, where we did, amongst other things, a very informative hemodialysis simulation, which was very high fidelity, and it's really cool to actually use the machine in a sim setting. Moving into kind of more of my talk. So one of the interesting things that I learned there was that there are new point of care creatinine testing machines that are actually available in Canada and are being used in Northern Alberta and BC. They're made by MaxPro, and my N of 1 at the very least was fairly accurate because my creatinine equates to a creatinine of 57 U-moles over liter, which is pretty similar to my lab values in Canada, although I kind of thought it might be higher with all the Argentinian steak that I was eating. And I think that this is cool because the company is also developing a point of care potassium test that's about the size of a glucometer, which is important because CKD is looking a little CKD care is looking a little more finerenone, as we're going to be putting the K into CKD with the release of the new CKD guidelines, as well as a bunch of research that's being done looking at finerenone and not just diabetic kidney disease. Because we know that finerenone actually reduces CKD progression in proteinuric diabetics by both directly targeting inflammation and fibrosis, and provides both proteinuria reduction, kidney and heart protection, in addition to SGLT2 inhibitors as an add-on therapy. And this was demonstrated in the combined results of the Fidelio and the Figaro trials, as I'm sure everyone on this call knows. But what was presented down south is that the Fineovate trial is or Fineovate program is a combined program looking at finerenone and its utility in non-diabetic and non-proteinuric kidney disease. For context, we're already using finerenone off-label for non-diabetic and non-proteinuric CKD in Vancouver kidney care clinics at provider discretion, analogous to, frankly, what we've been doing with ACEs and ARBs for a long time, which have less demonstrable evidence in non-proteinuric kidney disease. Finerenone is available in the BC formulary, as we all know. And what it's exciting to me about finerenone is it has a potential role in people that either can't be on SGLT2s or might have an additive benefit for patients that don't have a form indication for spironolactone, like patients with heart failure with moderately reduced ejection fraction, patients with type 1 diabetics, patients that are received a kidney transplant where there might be hesitancy to put them on SGLT2s, patients with PKD where there's a lot of hesitancy for several reasons, both mechanistic and lack of inclusion in trials to put them on SGLT2s, and potentially in GN patients for the same reason. And there's all of these trials that are going on that are looking at non-diabetic patients with CKD, for example, in the FIND-CKD trial, patients that are pediatric patients actually with CKD and a lot of protein, or patients with moderately reduced ejection fraction are going to be amalgamated into a FIND-REAL trial that'll be published in the next few years and is ongoing. And then besides finerenone, we might be going with the flow soon and prescribing a lot more ozempic, because as many people know, in October, Novo Nordisk stopped the flow trial early for efficacy. And the day later, it was actually published in Reuters that Ozempic's early success in kidney disease dramatically dragged down dialysis stock. So it was a bad day to invest in DaVita the day after the flow trial was published. And I won't be addressing it this presentation, but there's also a lot of talk about add-on therapy of both ASIs and ETA receptor antagonists, but that's beyond the scope today. So getting into the results of the flow trial, and these are all from photos that I took of slides at a talk at ISN. So FLOW is the first dedicated kidney outcome trial looking at semaglutide 1 milligram a day versus placebo in patients with diabetic proteinuric kidney disease, with a goal of delaying renal progression and lowering the risk of renal and cardiovascular mortality. There was a combined composite endpoint of a 50% EGFR reduction, an EGFR of less than 15, or initiation of renal replacement therapy, or a combined endpoint within a combined point of CV or a renal death. The trial was planned for 5 years, but stopped at about 18 months for efficacy, and will be formally presented actually next week for people going to Stockholm. But I have some spoilers for you here. So the inclusion criteria, so the trial took up 385 sites in 26 countries, both high and middle income. It included more than 3,500 patients with proteinuric CKD with an HbA1c of less than 10. It included patients that either had a GFR of 50 to 75 with a lot of protein, so an ACR of greater than 300, or patients with a lower GFR with ACR of 100 to 500. So in brief, these patients were high risk of progression and relatively sick diabetic patients. And all patients were already on RAS blockade, but there was some patients, about 15%, that were also on an SGLT2. And if you heat map all these patients, and these are their details that I won't read out, but you can look at it, they were basically the high risk of CKD progression as per the heat map. You know, they all fit into kind of the red category of likely to progress. And what they found was they actually met every single primary endpoint in addition to the composite primary endpoint. And they found a 24% risk reduction in kidney disease progression and cardiovascular death with a hazard ratio of 0.76. And that both the cardiovascular risk and the renal protection contributed to both risk reductions. And superiority was confirmed for time to first composite renal event being initiation of dialysis or a drop in GFR of 50%. There was a positive slope outcome, although they haven't released that yet. Stay tuned for next week. And time to first major adverse cardiovascular event and all-cause death and mortality. So look forward to Stockholm as some of our nephrologists are heading there, and we'll get the full results next week. And flow is also probably flowing into something bigger, as there's other trials going on about kidney disease and ozempic, and including a pooled trial that's going to look at several RCTs. There's a SOUL trial which is going to look at diabetics on Rybelsus, which is the oral form of ozempic, in addition to SELECT, which is going to look at non-diabetic patients that have cardiovascular disease and obesity and CKD. And interestingly, REMODEL is actually a mechanistic trial that's going to be doing biopsies and select patients with CKD, actually trying to come up with how ozempic might actually provide renal protection. And the reason why I'm going into all of this is pre-care is really hot right now, which is why, you know, there was a 2024 KDIGO guideline published looking at pre-care and revisiting it, which of course Dr. Levin is involved with, which is why she received her Dr. Ambanger Award, that and many other reasons. So pre-care, hot. What's also hot is anemia. So the clinical practice guidelines were released for public review earlier this week on May the 13th. They're not finalized and released for public review, but I'm going to highlight some big practice changing points in the next few slides to flag you all to go and read them, because they're very different and will very much change how we manage anemia if they're accepted and promulgated, with the big difference being focused on patient voice, lack of evidence for much besides symptoms with ESAs, but also a lot of benefits for iron. And this kind of comes from the fact that we know that iron deficiency is associated with poor outcomes, that people feel better when they're iron replete, and that these outcomes will often improve if you correct the iron. But there's been always a lot of hesitancy to give a lot of iron, and we haven't known how much to give, what TSAT or ferritin to target, due to concerns of iron overload. And it's tough to know when to start and when to stop. But as we also know, high hemoglobin targets with ESAs also increased risk. And the only benefit to increasing hemoglobin with ESAs is that we make patients potentially feel better if they were having symptoms related to anemia, or we reduce the risk of blood transfusions, counterbalanced against potential risk of vascular access loss from thrombosis, stroke, and potential malignancy that we always have to counterbalance. So the pivotal trial tried to address, at the very least, the iron question by randomizing patients to either a high ferritin target and a high TSAT target of greater than 700, or a TSAT of greater than 40%, or a low ferritin target and a lower TSAT target, similar to what we would use in our units, looking at both healthcare utilization costs, ESA use, blood transfusions, and whether or not there was any adverse effects. And this is a fairly large trial done in dialysis patients in 2019. And what they found was that the primary outcome was non-inferior, although there was a signal towards less mortality and cardiovascular outcomes in patients that had a higher ferritin and higher TSAT target, a signal that these patients felt a lot better and definitely used a lot less ESA and actually used a lot less blood transfusion, as opposed to patients that had a ferritin target of 200 and a TSAT of 20%. And this was done by loading patients very aggressively with iron. Additionally, what's been new since the last guidelines is a lot of evidence for HIF stabilizers, which I won't address in this talk as they were recently talked about in a province-wide rounds. So the guidelines incorporate all of this data and first state that in patients with CKD and anemia, not on dialysis, if profound iron deficiency is identified, for example, if there is a ferritin of less than 45, they should be referred to a gastroenterologist, gynecologist, neurologist, and started on iron as a first-line treatment. And in patients with CKD without anemia, they can be considered with patients with profound systemic iron deficiency, they should be started on iron, and the evidence is most robust if they have concurrent heart failure or if they have advanced kidney disease, and that the choice between oral and intravenous iron is based entirely on patient preference and local availability. The guidelines are a lot more specific about working up anemia besides just doing iron studies, and recommend looking for systemic disease as well as other nutritional deficiencies. And also say that if you do choose to use an ESA or I guess a hemoglobin increasing agent, that ESAs are preferred over HIF stabilizers in CKD and in dialysis patients. What's different is the hemodialysis population. So in patients with anemia on hemodialysis, not treated with ESAs, iron is recommended as per the results of the pivotal trial to start if their ferritin is less than 500 or their TSAT is less than 30, and to treat to a ferritin of greater than 700 and TSAT of greater than 40 before starting ESAs. And if you choose to start an ESA, to target a ferritin as per the results of the pivotal trial greater than 700 or a TSAT of greater than 40. And what's very different is the guidelines kind of abolish the idea of hemoglobin targets, acknowledging that the benefits of ESAs and targeting a specific hemoglobin are purely subjective and based on the patient, and that before starting a patient on an ESA or a HIF stabilizer, which can be decided at provider discretion, preferring an ESA first unless there's a compelling reason, but the patient should understand the benefit may only be symptoms, and the risk might be increased strokes, vascular access events, thrombosis, and potentially malignancy, and that the patient should understand that before starting an ESA, and that the only benefit, again, might be avoiding blood transfusions, and that hemoglobin targets on ESAs should be patient-specific. So for example, an in-center dialysis patient that you're just trying to make feel a little better might benefit from a target of 90 to 100, which is what the guideline kind of suggests for them, but it's much looser. But if someone is a pediatric patient or awaiting a transplant and still very active, a ESA threshold of greater might be better, understanding that the patient understands the potential risk of stroke or thrombosis. In short, patient voice is what's emphasized, and they're a lot more loose and provider and patient-centric. And additionally, the guidelines say that it's reasonable to suspend treatment if a patient has an acute stroke, vascular access, thrombosis, or thrombotic event, or if the patient is diagnosed with a malignancy, and this should be individualized. And additionally, if you need a hemoglobin target, they recommend 90 to 100, but it should be customizable. So in summary, I suggest that you all go and read the guidelines because they're a lot broader, both more and less specific at the same time, and will be potentially challenging to interpret in terms of center-wide policies, but are up for debate now. Their emphasis is on the patient voice, and they're a lot less prescriptive, and they focus on the clinical benefits of iron while minimizing the lack of clinical benefits of ESAs, and say that oral is fine and basically is whatever the patient prefers. Lastly, I'm going to talk about the new some new updates to the ANCA-Associated Vasculitis guidelines. And if you're interested, this was a great webinar that happened earlier this week, but is still available on the ISN website if you want to retune into it, looking at precisely what I'm going to talk about in a lot more detail. So as we all know, PEXIVAS was published a few years ago. It was a practice-changing study in the New England Journal of Medicine for PLEX in ANCA vasculitis and found that it was non-inferior to not using PLEX. But since the guidelines were published, although PLEX isn't specifically recommended, many providers haven't changed practices. And there's been many meta-analysis, particularly one that was done recently in the United States, that have found that particularly in cases of severe ANCA vasculitis with severe kidney-threatening disease or pulmonary hemorrhage, that many providers still choose to use PLEX, additionally for refractory disease. And there is a theoretical benefit to PLEX, which is why we did do it before, particularly in PR3 disease, which tends to present quicker, as it is thought that early PLEX in early disease may remove some circulating antibodies, or even in the case of seronegative disease, cytokines. And although there was no benefit for PLEX in the PEXIVAS trial, many meta-analyses that have been published since, including one recently that Dr. Walsh published in, found that there's maybe less end-stage renal disease at 1 year, counterbalanced with an increased risk of serious infection in the specially selected patient. So in light of this, the guidelines have kind of hedged to align with the EULAR recommendations that say that PLEX can be considered if a patient is presenting with creatinine of greater than 300, requiring dialysis, or have a rapidly increasing creatinine progressing towards dialysis, or patients with diffuse alveolar hemorrhage, but this should be discussed on a case-by-case basis and isn't a specific recommendation, and it also can be considered for refractory disease. And then additionally, the guidelines also include the results of the ADVOCATE trial, including avacopan as a potential steroid sparing agent that could be used as an alternative to glucocorticoids, particularly at patients at increased risk of glucocorticoid toxicity who are most likely to benefit, and in patients with low GFR who are more likely to benefit from GFR recovery. And if you're interested in avacopan, I've started several patients on it, and this is Glenys Webster's email from the Otsuka company, and it's on this slide as well. And the guidelines don't incorporate this as well, but there was a good talk that I went to about the potential benefits of avacopan for hypoxic pulmonary hemorrhage, and I'm just flagging this trial that everyone can read on their own time if they're interested. So in summary, things that were hot at ISN were essentially the 3 big guidelines that we're dropping this year, which is pre-care with some practice-changing medications, the anemia guideline out for public review, that iron is hot, ESAs maybe not as hot, and that are we bringing Plexi back? Did it ever leave? And avacopan is incorporated in the ANCA vasculitis guidelines. But what's most hot is BC Nephrology in both Montreal and ISN, as we've presented some amazing research down there. And with that, because IgA and hypertension are also quite hot right now, I'm going to hand things over to my colleague, Nick, who's going to talk a little bit more.
Okay, let's just see if this share screen is working. Okay. Emily, give me the thumbs up if you see it. Perfect. Okay, so this segment is called Nicolas in Argentina. So this is my takeaways from an amazing conference in Buenos Aires. Going to Buenos Aires was not only an excuse to clog up my coronaries with a lot of red meat and red wine. Just as a fun fact, apparently in Argentina, the average person there eats about 50 kilograms of meat per year. So that's probably about 50 kilograms on that plate right there. But going to Buenos Aires was also a great opportunity to hear some absolutely fantastic talks. And I just wanted to highlight a few that I thought were particularly interesting, knowing that my background is I want to go into transplantation. So one of the talks that I thought was great was a progress on xenotransplantation by Dr. Megan Sykes. And she was just talking about the different types of antigens that they've sort of identified over the years, the processes for trying to eliminate them in order to actually achieve xenotransplantation. And as you may have heard in the news, there was the first pig kidney transplant in the US in a living recipient about 2 months ago. Unfortunately, the patient passed away this week, but not for a renal-related cause, is what's been published so far. There was quite quite a lot of just general Canadian involvement at the World Congress as well. There was Caroline Lamarche at the University of Montreal, who's presenting her work on using CAR T and specifically using T regulatory cells in solid organ transplantation to help with immune tolerance of the graft. And CAR T is also being used to treat PTLD and solid organ transplantation. There's Dr. Sophia Ahmed from the University of Alberta talking about women's health issues, pre and post kidney transplantation. There were some excellent GN talks, one notably on membranous glomerular GN by Dr. Pierre Ranco from France, and a talk on MPGN by Sanjeev Sethi. So, and finally, an excellent talk on paraproteinemia in the kidney by Franck Bridoux and Sabine Karam, both in the native kidney and in patients with transplants. So I've included all the links here simply because if you've been to the ISN World Congress website, it's actually a complete labyrinth. So hopefully this is helpful to people interested in seeing the talks. And you do have to register, but at least when I was registering, it was only $10 to get access to the talks, so it's not too prohibitive. Now, the one talk that I really want to delve into today was my favorite one, which was the hot debate in CKD hypertension management, targeting systolic blood pressures below 120. So before we get to the debate, I just want you to get out your phones and scan out this QR code or go to slido.com and put in the number that you see at the bottom and just answer the following question. Should we target a systolic blood pressure of less than 120 in patients with CKD? So while you do that, I will be checking to see if there's been any sort of decision making on that.
Looks like a 50-50 split.
Yeah, from what I can see right now, it seems like it's a 50-50 split. Okay, so we're neck and neck right now. So let's see if it changes after I present some of the arguments from the debate. So before the debate started, this question was asked to the audience, and it was about 53% of the audience was saying that we should be targeting a blood pressure below 120. So why do people have that belief? So I'm sure you're all familiar with the SPRINT trial, but just as a reminder, this is the trial that really changed how we think about blood pressure and is published in the New England Journal in November 2015. And essentially, they randomized 9,361 patients to either an intensive blood pressure target or the standard blood pressure target, so 120 versus 140. It's important to note that the way they measured the blood pressure was using a standardized technique that we might not all be doing on a day-to-day basis in our clinics. So having the patient sitting in a chair, their back supported, their arm supported on a table, the cuff 3 centimeters above the elbow crease. The patient has to have their legs on the floor, their legs are uncrossed, they can't have coffee, they can't have any stressful thoughts, and they even specify in these guidelines the decibels of the ambient noise in the room for an ideal blood pressure measurement. So what's really important about this trial is that they actually had a pre-specified group of patients with CKD, which is why this trial is especially relevant in nephrology. And their primary composite outcome were the rates of MI or other ACS, strokes, heart failure, or death from cardiovascular causes. And there was a strong signal of benefit in this trial. So they actually stopped it early at a median of about 3 years because they found that the primary composite outcome was lower in the intensive treatment arm. So they had a rate of about 1.65% per year in the intensive group versus 2.2% per year in the standard group. With a significant confidence interval. So that gives about a 25% risk reduction and some pretty important outcomes. Now, not everything from this trial was sunshine and roses, because if we look at some of the rates of adverse events, if you look at the total rate, you don't actually see much of a difference. But when you look at specific adverse events, the ones that we would expect to be higher when you treat the blood pressure a bit more aggressively were indeed higher. So there I'm talking about hypotension, syncope, electrolyte abnormalities, and AKIs. And these adverse events actually led to higher rates of emergency department visits and possibly even hospitalizations. So with the SPRINT trial in mind, several international guidelines have actually changed their blood pressure recommendations. So I'm sure you're all aware of the ones that we probably use more regularly in Canada, including KDIGO 2021 and Hypertension Canada. And KDIGO just across the board recommends a blood pressure of less than 120 in patients with CKD. Hypertension Canada uses probably a stricter definition because they actually specify using SPRINT criteria. And SPRINT actually defines CKD as less than a gram per day of proteinuria and a GFR between 20 and 60. Other really important things to note are just the fact that patients with low GFR, high proteinuria, prior stroke, diabetes, autosomal dominant polycystic kidney disease were all excluded from the SPRINT trial. So it does leave a bit of a gap there. But not all guidelines actually agree with this recommendation. If you look at the International Society of Hypertension, they suggest either a blood pressure target of less than 130 or less than 140. The World Health Organization recommends essentially the same. And the ESH also recommends a blood pressure of less than 130. And these are in patients with chronic kidney disease. And finally, the ISH actually makes a recommendation to keep the blood pressure target above 120/70 because they're considering the adverse events that were brought up in the SPRINT trial. So that kind of leaves nephrologists and other physicians looking at the SPRINT trial and sort of interpreting it in different ways and not really being sure what to do. So that's why it was important to have this debate at the World Congress. And we had two heavyweights presenting. So on the pro side, we had Dr. Tara Chang, who's from Stanford, who's a nephrologist there, and she was one of the co-authors for the SPRINT trial, and she's also one of the co-authors for the KDIGO hypertension guidelines. And on the con side, we have Dr. Jordy Cohen from the University of Pennsylvania. She's a nephrologist and epidemiologist. And Dr. Tara Chang went first, and she presented the following arguments. The first is that from the results of the SPRINT trial, we clearly see that targeting a blood pressure of less than 120 is going to save lives, it's going to prevent cardiovascular events, and it's going to prevent kidney failure. So she probably could have just stopped the debate right there because that's pretty convincing already. But she brought up sort of the concerns that we have related to the adverse events. So first, she talked about how the SPRINT trial has a number needed to treat of about 90 for mortality and 61 for cardiovascular events. And this is basically a number needed to treat or benefit to statins, which we use pretty regularly. And this benefit was seen both in the CKD and non-CKD patients. She also brought up other studies, for example, this analysis of the ASK and MDRD trials by Ku et al. That was published in 2019 in the Journal of the American Heart Association, where when they analyzed other patients with CKD who were also targeting a lower blood pressure, they did find benefit in patients with lower GFR, higher proteinuria, and higher age. So these trials included patients that would have been excluded in the SPRINT trial. So as that kind of fills that knowledge gap. And she argues that the total rate of adverse events, if you exclude the renal outcomes, was similar in both arms. And if you are concerned about those renal outcomes, which most of us are, a follow-up trial actually showed that a majority of these AKIs actually resolved. So 90% of these AKIs resolved in a longer follow-up, and 26% of the people who developed CKD during the trial actually no longer met the criteria for CKD afterwards. So there seemed to have been some transient effect that they noticed. And they found that the benefit here at the bottom was actually significant for a lower rate of death in patients with CKD, so arguing that this target was safe and beneficial for them. Now, the con side was presented by Jordy Cohen, and she was arguing that the SPRINT trial actually didn't conclusively show that going under 120 is beneficial, and that maybe going under 120 would be harmful. And the points that she brought up was actually that the SPRINT trial achieved a mean blood pressure of 123 versus a mean blood pressure of 134 in the standard treatment arm. So her main point was that maybe if we just target below 130, that would be sufficient. She actually refers to another trial that was done after SPRINT that was inspired by SPRINT called the STEP trial, which was done in China, where they targeted a blood pressure of 110 to 130 versus a blood pressure of 130 and 150. And then this trial showed a similar benefit to the intensive treatment arm, but they only achieved a mean blood pressure of 126. Some analyses have shown that in order to get the blood pressure below 120, you might require 1 to 2 more blood pressure agents to do so. And that even though the number needed to treat that we saw before was, in the 60s or 90s, depending on which outcome you're looking at, the number needed to harm was actually lower at 50. And one excellent analysis by Bress et al. Published in 2017 showed that if we adopted the SPRINT targets across the board in the US, this would lead to 107,000 fewer deaths, but at the expense of 220,000 more adverse events and possibly hospitalizations. So that obviously is concerning. So with those kind of debate points in mind, I'd like you to join the poll again. I'm just going to open question number 2. And you can let me know what you think. If you've decided to, we were at 50-50 before. So I'll give that a few seconds. And we'll see. So right now we have, some people have changed their vote. So we're now at 33% are supporting the blood pressure target of less than 120, and 2/3 of people are supporting another blood pressure target. So in the end, how did the audience vote? So in the end, the audience was swayed by Dr. Jordana Cohen. And in the end, almost 70% of people said that we should not be targeting a blood pressure of less than 120. My major takeaways from this excellent debate were as follows. One of the arguments or the discussion points after the debate that was brought up was that a blood pressure target is not always the same thing as your achieved blood pressure. And what Dr. Tara Chang was kind of arguing was that getting setting the blood pressure target of 130 will mean that of less than 130 will mean that maybe most practitioners will be happy around a blood pressure of 130, which we know is not necessarily as beneficial as something that's maybe in the mid 120s. So she's afraid that by setting the blood pressure target too high, we're actually going to be under-treating our patients. Whereas Dr. Jordan and Cohen's counterpoint to that was that argument seems a bit paternalistic, and maybe we just need to say the blood pressure should be within a range of 120 to 130. I think another major takeaway is, as much as possible, we need to find a practical way of implementing standardized blood pressure measurements in our clinic, because if we don't, then we won't be able to really use these sprint criteria. We won't be speaking the same language. And then another important takeaway is that we eventually need more blood pressure, dedicated blood pressure target randomized controlled trials in our CKD population without any sort of major exclusion criteria. And finally, the major takeaway I had is that maybe this debate format of presentation is a more effective way of improving the understanding of complicated medical topics and trying to understand conflicting evidence and recommendations. So I would actually advocate in having more of these debates, maybe even in this setting in province-wide rounds. So thank you everyone for your attention, and I will bring it back to Emily.
Thank you, Nicolas. I'm just going to share my screen. And thank you all for attending as we dance our way out of R5. And I'll open it up to the floor for questions now.
Okay, thank you very much. So I think it's great that you guys summarized and some of the key things, and I agree with Nicolas, that was probably one of the best debates that I have heard on blood pressure. Maybe we can stop sharing the screen and answer some questions and put the panelists back up. So there were some questions around sort of customization of blood pressure and that it differs from patient to patient. And so I don't know, Nicolas, was that addressed in the debate, or what are your thoughts about that?
Yeah, that was addressed. So it was kind of interesting because you could see even Dr. Chang's kind of point of view being shifted after Dr. Cohen went, because she kind of came out saying really quite strongly and emphatically that we should be targeting a blood pressure of below 120. And then after the discussion period, she was kind of insinuating more that we should really try to aim for that 120 blood pressure mark. So at the end of the day, you have to individualize, because if you get to a blood pressure of 130 and the patient's getting some of those adverse events, hypotension, syncope, electrolyte disturbances, obviously you're not going to push. And if you have an 80-year-old patient, even though we know that lowering the blood pressure in elderly patients is beneficial for many different outcomes, you might be a bit more reticent. But I think her argument is just you should not rob your patient of that opportunity to get their blood pressure as low as possible.
Yeah, I think the achieved blood pressure was like 124 in the 120 group, and in the 130 group it was 129 or 130. Like, so it's kind of interesting, like what you target is not what you get, which I think you said. So two people have their hands up, Marie Michaud and Carolyn Stigant. C is before M, and I think Carolyn, you were up first. So Carolyn, we'll unmute Carolyn, and then we'll unmute Marie. Thanks.
Okay, thank you. You can hear me?
Yep.
Thanks, Emily and Nicholas. Nice to see you both. Just great summaries. Although I appreciate environmentally sustainable kidney care is not a late-breaking topic, I guess wanted to get a word in to say how it's a theme that ripples through all of the presentations that were at WCN. And we did have 2 presentations there, and it's tough to get traction in this area. Again, this wasn't specifically a Congress or a CSN topic, but maybe to draw to people's attention in the recent New England Journal, something I was really happy to see, and that was carbon footprint analyses and RCTs towards sustainable clinical practices. And so they're calling for integration of environmental data along with clinical outcome data, and as well as cost data. So looking at that so-called triple bottom line. So it would be interesting for me to hear if at any of these trials that you attended, if there was any environmental metric that was included in that, and your thoughts on how we might be able to integrate that better. And maybe just in case people aren't aware, I know there's another HDF clinical trial that's ongoing. And so we were fortunate to speak to the investigators there, and very happy to hear that they're going to include LCA in that as a definite outcome. So just would welcome your thoughts on that.
So to my knowledge, I don't think it's been incorporated in any of the clinical trials, but I know that we're trying to look at interventions in BC and, as you know, and how they might impact environmental footprint. And I will do a shout out for you, Carolyn, that for the first time ever, when you do a talk, you actually describe your environmental footprint as one of your disclosures, which I think is a really another fantastic way to socialize the concept. And so I want to know how you calculate it so I can put that on my talks as well.
Oh, I'll share you the link. Yeah.
Okay, great. That's
Great,
terrific.
thanks.
Thank you, Carolyn. Marie, your hand's up.
Hi. First, thank you for the summaries. I thought that they were excellent and I really enjoyed them. Then second, I just have a really specific question on finerenone, actually. As I'm starting to transition patients over to finerenone, I have patients on spironolactone that are also on an SGLT2 inhibitor and an ACE or an ARB, diabetics with proteinuria. And I wasn't sure what to do with that patient population, particularly if the spironolactone was partially for blood pressure. I don't know if anybody.
I mean, I can answer it unless you, Emily, do you want to answer it? Or
So I'm Dr. Levin, please chime in. So my interpretation of the literature is if someone has a class 1 indication for spironolactone, for example, heart failure with reduced ejection fraction, or you're using it to treat like primary hyperaldo or hyperplasia, that spironolactone would always be your #1 choice. But and Spiro, because it's a longer acting drug, will always provide better blood pressure control rather than finerenone, which is a shorter acting drug. But if you're using the drug for proteinuria reduction or for CKD management, then finerenone actually probably binds a bit tighter to the receptor and probably has better proteinuria outcomes just based on trial data. But Dr. Levin, I'd be curious your thoughts as to that. So I guess the answer to your question in summary is if you're using it for blood pressure, Spiro is probably better and has some proteinuria reduction, but if not, finerenone would be your go-to, acknowledging that Spiro is probably a lot cheaper.
I think, yeah, the studies haven't been done looking at that, but interestingly, whilst the finerenone studies were done without a goal of blood pressure reduction, the median blood pressure reduction is about 3 to 5 millimeters of mercury, which is not nothing. So I think you're right. Like the current indications for Spiro are heart failure, right, and primary hyperaldo. They're being tested, but Marie, if you've got people on SGLT2s and ACE with proteinuria and diabetes, you're probably justified, and they don't have another reason, that you're probably justified in trying finerenone because it has disease modifying effects that are not necessarily seen with Spiro. I think the people who were studied the most are the people who were Spiro naive, like they were not aldo blocker exposed, and that was what most of the finerenone studies looked at. But great questions. Mark Elliott has a question. Thanks for the excellent talk. Curious where this push for Plex and ANCA continues to come from, especially because Mike Walsh is the lead author of Pexivas and continues to promote it on all of the secondary and post-hoc outcomes, with the results were quite resoundingly negative. And I think that is a really important point, because the meta-analyses never replace an RCT that was done, so it's kind of curious. And then he has a similar comment about the blood pressure, the no-act gap, and how aiming low actually helps with the mortality benefit. Go ahead.
So about the Plex point, so the talk that I went to that talked about it basically was as wishy-washy as I tried to make my slide to be, and I think as the guidelines are trying now, basically just saying that there may be a benefit in certain people. It's worth an opinion and it's worth a discussion, but it's not necessarily something that we should or shouldn't be doing. But in those patients, maybe talk about it in the specially selected, but I agree with you. It's all very wishy-washy with a negative RCT.
Yeah, I think we have to be careful about opinion versus, and Miriam, you have your hand up because you want to make a comment.
I do, yes. So as you know, and as you've stated, Emily, the evidence is confusing because the meta-analyses that we're looking at place a lot of weight on smaller and not well-designed trials and take away from Pexivas, which was a big trial and had negative outcomes. So I think we have to be very careful with guidelines and meta-analyses, which is why our approach is really collaborative in nature and sort of takes into account the overall context of the patient. But I think you've covered it very well in that we really don't know for certain for the patients that end up getting Plex, whether it was the Plex that worked or something else. And I doubt that those trials will actually ever be done, because I just don't see the numbers for, Plex in patients who fail this and are refractory to that and still have, X, Y, or Z condition. So I think, as we talked about in the past, guidelines is super helpful, but if you look at the source data, I don't think that we can agree that every patient who's dialysis dependent or has severe, quote unquote, severe renal disease should be on Plex. And if you actually look at the pulmonary hemorrhage data, it's even weaker than anything else. So it's okay to remain perplexed, as you would say, Emily.
Yeah, and I think that that's one of the values of having, good follow-up in registries or databases, so that in the real world, we will accumulate, what was done and why, and then what ends up happening, which is not the same as an RCT, but at least adds, because you're right, Miriam, I don't think we'll ever do that Pexivas trial again, although we probably could and should, because we can answer additional questions, but that's beside the point. I know that we're at time. And I'm very respectful of that it's a Friday of a long weekend, and people may have to do some other things. So I want to thank you and Nicolas, and I know that Michael had also put together some slides but is unwell today. And thank all of you who attended. We were over 50 people, which is pretty terrific on a Friday morning in the summer, spring, whatever this is right now. So thank you very much for both attending and also the conferences, and also bringing back to BC your insights and your thoughts. So very much appreciate the work you've done. And thanks everyone for attending. Happy Friday.